Okay, part of the beauty of having 13 different budget proposals is that breaks are forbidden for the rest of the day. So I'm Michael Greenstone. I'm the director of the Hamilton Project. And I'm going to just take a few minutes now to explain what we were trying to accomplish when we began work on this fabulous book, 15 Ways to Rethink the Federal Budget. And we began about 6 months ago. So the first thing I want to say is before I start to describe the authors and the papers is this could not have happened without the incredible work of the 15 sets of authors and of at least equal importance, this very small, scrappy Hamilton staff who had a tsunami of 15 papers arrive over the transom more or less simultaneously. So the starting point for when we set out on this project was the observation that the budget discussions are generally taking place at a very high level. In the parlance of DC, these discussions are about the super committee, the fiscal cliff, the debt ceiling, the continuing resolution, the sequester, as Alice said, the various gangs, and on and on and on. All of these discussions take place at the level of hundreds of billions of dollars. And indeed, these high-level agreements are critical, and despite the political messiness, really are, to press a metaphor here, the poetry, I think, of budgeting. However, beneath this poetry is the nitty-gritty of actual policies that can make people's lives better or more challenging. This includes decisions that determine how much pollution we're going to put in the air, access to health care, the size of people's paychecks, whether they can work in the U.S., and whether our nation is secure. These more micro decisions we like to call the pros of budget deals, and they really matter for people's lives. There's no question that the continuing consolidation of the federal budget is going to pose challenges, but we believe that it also offers opportunities. And these opportunities don't present themselves very frequently. It can be very difficult to make fundamental changes in the way things operate during normal times. However, we're in a period where larger changes can be contemplated, and this provides a special opportunity for policymakers to decide what type of country we're going to be in the coming years and decades. But sound decisions require a budget debate rooted in facts, not ideology. And so it was with this background in mind that we went to experts around the nation and asked them for their single favorite pragmatic and evidence-based policy proposal that both helped address the budget deficit and had broader economic benefits. The folks we asked, and you're going to meet them throughout the rest of the day, are truly rock stars in a wide variety of areas. They include a retired four-star Navy admiral who was formerly head of naval operations. Let me just add as an aside, one of my favorite parts of the process of producing this book was watching one of our young research assistants try to provide direction to the four-star admiral over email. Another author is a person widely credited with designing the Massachusetts healthcare system and deeply influencing the shape of Obamacare. We have faculty from leading universities around the nation. We have the leading expert on the economics of immigration in the nation, the president of the National Hazard Mitigation Association, foremost budget experts in D.C., former undersecretary in the Department of Transportation, and that's just to name a few of the authors you're going to meet today. And what came back from these authors, I think, was truly astonishing. 15 insightful policy proposals. While not intended to cover every budget category, these papers take on a wide-ranging set of topics that we've grouped into 4 categories. The authors on today's first panel, who are about to come on stage, focus on ways to improve entitlement spending by reforming disability insurance, Medicare, and natural hazard and mitigation programs. The second panel's authors propose innovative approaches to tax reform by taking a close look at fossil fuel tax subsidies, the home mortgage interest deduction, and other aspects of the tax system. The third panel's authors suggest new sources of revenue and efficiency, including instituting a carbon tax, auctioning work visas, and greater use of user fees for transportation infrastructure. The fourth group's proposals were discussed at an event we held last Friday, and they offered plans for responsible cuts in the defense budget. Viewed individually, the proposals offer specific reforms and evidence-based policy ideas to achieve budgetary savings and broader economic benefits. Taken together, they offer a menu of policies that could contribute meaningful deficit reduction and help the country confront its many pressing economic challenges in the years ahead. So with no further ado, I will now turn it over to Laura Tyson, who's going to moderate our first panel.
Good morning, everyone. It's a great pleasure to be here. As a member of the advisory board of the Hamilton Project, I much too rarely get an opportunity to be in Washington to chair a panel like this, so it's a real thrill for me. I have an outstanding panel, and I just want to go back to one thing Bob said, and I think Michael said as well. The Hamilton Project has always been about fiscal responsibility, but it's been fiscal responsibility with progressive growth. So it's a very important panel to start with, because this panel is looking at fiscal responsibility, but along with an enduring social safety net. That is what this is about. It's sensible deficit reduction for a social safety net that endures and works for our citizens. So that's the first thing I want to say. Now, I want to just do a very quick review of the makeup of the panel. First of all, following right on from the last panel, we have two papers that really deal with Medicare, which basically is the single biggest driver of our long-run deficit problem. There is, as we heard about, promising evidence, intriguing evidence of a slowdown, but as you will hear from our panelists, there are still very significant issues of whether that slowdown will be sustained and whether it will be sustained in a way which gives the quality of service to our population that we want to achieve. We have a very ambitious baseline, and can we do it? So first you'll hear from Professor Michael Gruber. He is the professor of healthcare policy at Harvard.
Michael Chernew.
Excuse me, Michael Chernew.
I could be right. John, though. That would be good.
These guys are, they go right across the street from
like
one
brothers.
Another, and they work on, yeah, but you're absolutely right. Michael Chernew, he is at Harvard. They're both, and one is at MIT, professor of healthcare policy at Harvard Medical School. His paper is co-authored with Dana Goldman, USC, and he's going to talk about proposals to actually work on the supplier side incentives through a global payment reform to try to achieve those very ambitious projections for Medicare savings that are in current law. And so we'll hear about how to do that. His proposal looks at incentives among suppliers. And actually, Michael, one of the things I found most intriguing about the last panel was a suggestion that providers who are female are going to behave differently, and that it may be easier to achieve this global payment reform as the number of women who are in the healthcare profession increases. Very intriguing idea. We are then going to turn to a shift to the demand side. And this is from Professor Jonathan Gruber. Now I have Michael and Jonathan by correct last name. Professor at MIT. He is, as Michael indicated, there's someone here who can be viewed as largely responsible for the Massachusetts healthcare reform and much of Obamacare. That's Jonathan. Jonathan is going to talk about reforms on the demand side, and in particular on the Medigap, or supplemental insurance system for Medicare. When I read his paper, which really talks about how aggressively to go after Medigap insurance, for example, by a very large excise tax, I thought of myself approaching the age of Medicare and thinking about how I might feel about that. So that's a very interesting idea. We're then going to be joined by Professor Jeffrey Liebman. Now, he is a professor at the Kennedy School. There's a lot of Boston, Cambridge concentration going on here. I can say that from Berkeley, California. However, I am an MIT alum, so it's okay with me. Anyway, this really is to look at a different part of the social safety net, which doesn't get nearly as much attention. This is a disability insurance. Now, as his paper points out, disability insurance, the big run-up, may be changing with the demographics, because a lot of people from 55 to 65 have gone into disability insurance. They will then go into Medicare, into Social Security, and off the disability rolls. But it is the case that if we could reform the system to provide better incentives for employers to train people to go back to work, to encourage states to work to identify the truly disabled from those who claim to be disabled, to identify with the federal government the way to actually make the federal disability insurance policies work better, we could save a substantial amount of money long term. So not an immediate pressing budgetary problem, but an area where reform would be terrific. And then finally, in a very different way altogether, we don't usually think of social safety nets as dealing with disaster relief. But two things are pointed out by our author Edward Thomas with his co-author David Conrad. Number one, more extreme weather events and disasters. Number two, a rising share of those costs of disasters being borne by the federal government. A significant increase in the share being borne by the federal government. And by the way, what's the moral hazard associated there? I live in California on a fault line. I have earthquake insurance. Most people tell me I am absolutely crazy to have earthquake insurance, and probably that is correct, privately speaking. So this is basically the panel. I want to start with a general observation. I don't know how many of you read Freakonomics years ago, but Freakonomics was really based on the notion that crazy incentives lead to crazy behavior. In every single one of these papers, the story is about crazy incentives leading to crazy behavior. And if we reform, we get both budgetary savings and we get much better behavior. So I'm going to start with Michael Chernew to talk about his global payment reform. Ask him to talk a little bit about these baselines, these two different baselines and savings from that. And then how do you see your reform encouraging improvements in the quality of care?
Well, thank you. And I'm thrilled at the attention Medicare is getting in general, and agree that figuring out how we're going to address Medicare and preserve high quality care for the beneficiaries is a huge challenge. So I told myself I wasn't going to talk a lot about math, and I'm really not going to talk a lot about math. But it turns out that how much money you save has a lot to do with what you compare it to. And a lot of stuff has been going into the current law, existing current law, that has already reduced the trajectory of Medicare spending. So I'd like to think that in many ways we had Medicare reform. Historically, Medicare spending per beneficiary has grown at about 2% faster than GDP, depending on when you start, when you stop. Current law, Medicare beneficiary spending growth per beneficiary is about GDP minus 0.7. We've never come close to minus 0.7. Now, some of that minus 0.7 reflects some nuances of the law, the physician payment system called the sustainable growth rate, which has consistently been overridden. So when we think about what you're going to save, the question is, are you going to assume current law that has this reduction in physician fees, or are you going to assume history will hold and that will get overridden and you're saving relative to a somewhat higher baseline? So our proposal is designed to change payment, but the scored saving number there is relative to what we consider the more realistic alternative scenario, where there's about 100 billion, it's really 138 billion, as opposed to the current law baseline, which is much lower. What that means, of course, is if you want to think about saving money in Medicare, and I can tell from the prior panel, everyone wants to think about saving money in Medicare, understand that the target you're shooting for is GDP minus 0.7 on a per beneficiary basis. That's astounding. Mm-hmm. So my general view is the way that one's going to save money, relative, if you needed to save money compared to that, you're going to have to do a lot of shifting to beneficiaries, which I'm not going to talk about very much. But I do think the motivation for our work wasn't to save money relative to GDP minus 0.7. We basically had two motivations. One is try and find a way to get there, or somewhere close to there, that's efficient as opposed to just slashing prices. So that's the main goal. And without going into a lot of detail or anecdote, the way that the Medicare program is designed, as all of you know, is incredibly fragmented. We have a system for physicians, we have a system for hospitals, we have a system for long-term care providers of multiple types. The fees we pay for the same services vary based on where you're getting the services, and often if you have a surgery, for example, we're paying the physician separately from the way we're paying the hospital. There's complicated aspects of geographic adjustments that are going on, and complicated issues of coding. You know, is this a, you know, there's 15 codes for office visits. with remarkable details about which one is which, and we spend a lot of time arguing about how the coding is working and whether we need to claw back aspects of money from various providers because they have somehow changed their coding to get more money out of the system. In that fee-for-service world with all that fragmentation, the provider system does not have the incentive to reap any efficiencies. If you reduce utilization of the hospital loses revenue. If you coordinate, there's no incentive to invest money to coordinate care with some other provider that might reduce the total amount of care delivered. And so the idea of a broader global payment that we discuss is really to set up a system that allows the provider structure in the United States, which is really the fundamental foundation of the healthcare sector, to capture the efficiencies that they might be able to gain. What I say when I speak to providers is, when the money gets tight, which it surely will, you want to control the money. You want to allow the most flexible substitution across sites of care, across use of services that you possibly can to promote efficiency. Now, I will say I'm under no illusion that this is a simple or easy thing to do. The organizational changes in many places are enormous, and I don't think that one should say that this is simple in any particular way, but I think compared to the alternative, it is a valuable way to go. And I think the experience in Massachusetts, which I was originally more skeptical of, has suggested the system, in fact, can transform itself reasonably well. So their challenges are huge, but unless we have a system that allows people to have incentives to become more efficient in their provision of care, I don't see how we're going to get the high quality of care that we need with the budget's costs that we...
Can I just a quick follow-up? Because one of the other points made in the last session was that one of the consequences of the Affordable Care Act is going to create much more powerful provider groups. So you have pricing pressure being built into the system. And so if you have these global payment systems and you detach it from fee-for-service, well, it's not clear what you attach the payment growth to over time, particularly with these powerful provider groups.
Well, so fortunately this was a paper on Medicare where you have some price regulatory authority, but the fact is true that almost all of the reforms we've seen both want to get rid of the fee-for-service system and then build payment on the basis of what's going on in the fee-for-service system.
Right.
So we have a ways to go in terms of thoughtful construction of how these systems will work. And in fact, a lot of our paper is devoted to how you might do that somewhat more mundane technical activities. But we believe that the right that the government can set in Medicare is a political decision, and we just picked current law, so it would be you could pick faster or slower. In fact, I think that would be important. The point you raise, and I agree with it completely, is outside of Medicare, as the provider system changes, we have to worry a lot about the market power that goes on as the delivery system consolidates. And so maybe I'll be invited back to write another paper about how we're going to deal with antitrust
So
outside
basically
of
what would
Medicare.
happen is you'd have these powerful provider groups, but in Medicare you'd have the cap. And the cap you're basically saying is current law at the trajectory.
In Medicare, you could set the, we propose, so, we propose that the government would set the fee, this global fee.
Global fee.
And they will do that administratively as opposed to tying it to fee-for-service. But
Right.
of course, you would need to set faster or slower based on how much, medical technology you wanted to encourage or discourage, how much taxes you wanted to have.
Right.
It's clearly a complicated political question, but at least whatever you decide, you can get efficiency within that.
It's better, yes.
Right,
okay.
you certainly want to, whatever you spend, you want to be efficient with it.
Within it. Okay, let's move to the demander side. So we have the incentives messed up for the supplier side. The demander side, overutilization. The hospitals want to provide the service, the doctors, people want to use the service. Part of this is the fact that we have wraparound insurance and we have employer-provided healthcare coverage to pensioners. What shall we do? What shall we do about that?
What are you pointing at?
We're pointing at you.
Oh.
You're up there.
Oh, I
Each of
see.
these has a title.
Oh, gotcha. Okay.
Your correct name as opposed to my incorrect, and
Gotcha.
then
All right,
the
fine.
benefits.
I just know that Michael, but my shirt was unbuttoned. Michael's pointing. I don't know what's going on. So first, I want to thank Michael and Hamilton for having us here and for putting this panel together. I think this is terrific, especially in this era of lack of thought in the budget process to have this thoughtful panel put together. I think it's terrific. So I think Laura's exactly right. If you look at the history of Medicare reform, Medicare policy discussions, they're almost exclusively on the supply side. There's been enormous change to the supply side of Medicare over the past 30, 40 years, and there continues to be. But in fact, the demand side of Medicare is largely fixed where it was when the program was introduced. In fact, the biggest change to the demand side was just an expansion of Part D, adding Part D in 2003. And it's really a demand side that doesn't make sense. If you think about how the demand side of Medicare works, you have a certain deductible if you go to the hospital, but that deductible is per hospital event. So whether your second stay is called part of the event or not can determine whether you pay an extra $1,200 or not. You have payment, which is you pay per day you go to a skilled nursing facility. It can add up to $10,000 if you're in a skilled nursing facility for 100 days. You have a coinsurance for doctors, which is 20%, which economists will tell you is a rational way to organize care, but it's uncapped. So if you spend $100,000 at a doctor in a year, which an elderly person could well do, that's $20,000 out of pocket to you. That makes no sense. Then you have services like home health care and clinical diagnostics, which are delivered free at no care to the patient, and so are clearly going to be overused. This system's been in place for a long, long time, and it's time to reform it. And there's been a lot of discussion about this, and really what I propose in mine is really a reform of ideas that have already been put out there, which is to do two things. First, to reform the cost sharing in Medicare, and the second is to reform the supplemental insurance people use. Because people, to deal with this cost sharing, in particular this unlimited risk, people turn to supplemental insurance, most commonly Medigap, which is individually purchased supplemental insurance, or retiree insurance from their employer. As well, we have Medicaid from the public sector and Medicare Advantage HMO plans. These supplemental plans, particularly Medigap and employer insurance, have two flaws. The first is they exert what we call a fiscal externality on Medicare. It's just fancy terminology for the fact that if Laura's on Medicare and doesn't have supplemental insurance, and I do, and I use one more doctor's than she does because I have this extra insurance, Medicare bears 80% of the cost of that extra doctor's visit. But my Medigap insurance only bears 20%, and yet so basically they're exerting this externality, this extra cost on Medicare. That's very large. That's been estimated to be between 30 and 45% of the cost of Medigap is the size of the externality it exerts on Medicare in terms of higher spending. The second problem is Medigap is really not a very good insurance product. You may know that in the Affordable Care Act, after some debate, we regulated that insurers should have a medical loss ratio, that is the ratio of what they spend on medical care to the premiums they collect, of 80 to 85% after some controversy. For Medigap, that medical loss ratio is about 65%. That is, Medigap insurers spend about 35% of what they collect on advertising, administration, and profits. So what do? What we do is two things. What I propose to do is two things. First of all is to move to a more rational cost-sharing system for Medicare. This would have three features. First, it would have a small deductible at $500. Then it would have, first it would integrate Parts A and B into one system. You'd then have a small deductible at $500. You'd then have a 20% coinsurance, but you'd have an out-of-pocket limit. Okay, this idea dates back to 1988 with the catastrophic reforms that failed in Medicare, have an out-of-pocket limit. But what's different about my projection is when people talk about out-of-pocket limits, they've talked about numbers like a $5,000 out-of-pocket limit. We have to appreciate half of seniors live below 2 times the poverty line. Okay, a $5,000 out-of-pocket limit at 2 times the poverty line is 25% of income. Okay, that's not feasible to ask seniors who are high spending to year after year spend 25% of their income on medical care. So what I propose is actually an income-related out-of-pocket limit, where seniors, as a function of their income, would pay lower limits and it'd go up as their incomes go up. It would parallel actually what we've just done the Affordable Care Act. So an income-related out-of-pocket limit. My other proposal is to, and that proposal actually, by the way, doesn't save money, it actually probably costs money. If we take Medicare and put in the system I described plus an income-related out-of-pocket max, that probably costs money. That's why I'd pair it with a tax on Medigap plans as well as employer insurance that compensates Medicare for the externality those plans exert on the Medicare program. Now, I don't propose a rate of the tax. The score up there, the score $125 billion is based on an estimate from the Office of the Actuary, from MedPAC, which uses a 20% tax. We can vary that rate. But the idea is essentially rationalize the cost sharing under Medicare so you no longer really need this supplemental insurance. And then if you still want it, that's fine, but you should bear the cost it imposed on the Medicare program. Thank you.
Can I just ask a quick follow-up? Because the tax part of this, which is the way you save the money, is actually, think about I guess it's not a fair question, the feasibility of this after a long, long fight to get a serious reduction in the employer tax deduction for health insurance. And all we really got was extreme Cadillac plans with a tax increase. So this is a pretty hefty tax increase to raise revenues. Have any thoughts about the feasibility of this?
Sure. Okay. So first of all, I'm excited because of the Cadillac tax. And let's remember the Cadillac tax. Remember that starts at a high level, but it's indexed only at overall inflation, not medical inflation.
Okay.
So it becomes lower over time.
Over time?
And that may be the way to do this too. It may be to have a long phase-in, something like that. I agree. I think like this is a heavy lift, but I think that we have to recognize the enormous costs. If we recognize the costs, if we do three things, we recognize the costs imposing on Medicare. We recognize the enormous inefficiency.
Right.
So you know that the main provider of Medigap pays AARP about $250 million a year to use their name to advertise their Medigap program, and that's what seniors are paying for. And we recognize that in a rationalized cost-sharing system where people are protected against extreme costs, we don't need to have that supplemental coverage. I'm hoping to put those together, a case can be made.
Oh, that's fantastic. And I think the point about the Cadillac and then looking forward to it phasing in over time is very important. Okay, let's turn to disability insurance. And I really want to point out something very distinctive about this paper, because this paper does not say, we know exactly what to do. This paper says we need to have a series of pilots to know what to do. And a very important part of this paper is we have real problems funding pilots because of discretionary spending caps. And we have real problems enforcing the current disability insurance law because we can't even handle the backlog of cases under review for disability insurance because that's discretionary spending. So very important observations about the importance of doing pilots, demonstrations, and lack of discretionary spending. Jeff.
Great, thank you. The first thing I want to say about disability insurance is it's a leading indicator about what we're going to see with the rest of our social insurance system. The same baby boomers who are about to be 65 and 75 and swamping Medicare and Social Security retirement have been swamping the DI system because they've been 50 to 65, which is the peak years of disability incidence. And so the reason that DI spending, primarily the reason it's been going up over the last 20 years has been the baby boomers have suddenly been getting into these peak DI years, along with there being an increased number of women in the workforce who are covered by DI. The second thing I want to say is there are basically three challenges that our current system is facing. The first one is that there's a portion of the disability population, perhaps a third of it, for whom it's really what we're giving people is the wrong type of benefits. What we're saying to people is we will give you lifetime cash benefits as long as you never do significant work again in your life. And there's a portion of there are many people on DI, the majority, who probably can't do significant work again, but there's a portion for whom would be much better off if we could help them get back to work and offer them a package of support that help them get back to work. So that's the first thing I want to say about the challenges to the DI system. The second thing that's a challenge is that there are all sorts of incentives that are messed up in this system. Employers have an incentive if an employee becomes disabled to basically get them on DI so they're not their problem anymore. State governments have incentives to take everyone they can who seems to be eligible for public assistance paid for by the state and get them on SSI or DI so that the federal government pays. And as Laura explained very clearly, the Social Security Administration has this incentive because the discretionary spending that funds its administrative expenses is limited, as all discretionary spending is these days. What the Social Security Administration does is they make lots of decisions that save money in the discretionary budget but cost way more than they save in the mandatory side of the program in program benefits because they don't have an adequate budget to basically to develop the evidence as thoroughly as they should and to do the continuing disability reviews of people who are already on DI to see if they're still eligible.
Can I just interrupt for a moment? Your number in that respect was really significant. I think it's the $1 spent saving $9 of
The actuaries'
unbelievable.
estimate is that for every dollar you spend doing a continuing disability review, you save $9 in benefits, and yet we have several million backlog in disability reviews, basically because we don't have enough staff in the DI system to do the front door, and so because we don't want the wait list to get too long for people applying, we can't do the reviews on the back end. So one of the things we propose in this paper is most mandatory programs, the administrative funding is on the mandatory side as well, and we propose to switch the funding for the state disability determination systems over to the mandatory side of the budget so that SSA can actually do their job right, which will, we think, on net actually save money to the federal government because they'll get the benefit decisions more accurate. But the second thing we work on in this proposal is trying to figure out how we can develop a system of support for the people who can go back to work, but today are ending up on DI and typically for the rest of their lives once they start. And as Laura said, that's something where we think there are a number of good ideas out there, but we actually don't know the one best solution that should go nationwide at this point. We're basically in the same kind of situation we were with welfare reform, let's say in 1980. Before all the states did their experimentation, we did all the pilots, and then eventually by the mid-90s, we thought we knew enough to do welfare reform. We basically need to unleash that kind of experimentation in the disability insurance system. And so what we call for is 3 types of pilot programs. And the basic idea behind all of them is the earlier you intervene, the better. If you wait till someone's already receiving benefits, especially given how long it takes to get through the application process, they've been detached from the labor force for a long time and it's too late. And so you want to intervene before people are actually receiving benefits. So the sort of last moment you can intervene and have it be before they get benefits is when they apply for benefits. And so one kind of pilot we proposed would be to target a subset of the DI applicants who look very likely to get benefits, but also like they have some capacity to go back to work, and to offer them in exchange for dropping their application for DI, instead they would get a package of assistance that would include support at getting back to work, an EITC like wage subsidy, and some other things. So that's sort of one type of pilot we need to do. But we also think we need to do pilots based around firms that give firms a better incentive to try to keep their workers employed rather than putting them onto the DI system. And we also have to give states the incentive to package all the different federal streams of money that come to them to deal with the disabled population in more creative ways and give the states basically shared savings so that if they can produce savings for the federal government by doing a better job of keeping people off these federal programs, the states would actually share some of that benefit.
Fantastic. Thank you very much. All right, now we turn to our last panelist before we move on to our discussant, Edward Thomas, and he's going to be talking about how to limit transfer of costs of federal disaster relief that's going on to the federal government. So my question to you, in a sense, is this about shifting the costs from the federal government to some other place, a state, a person, a citizen whose house has fallen into the water, or is this a proposal to reduce the costs of disasters, or what's the combination?
This is very much a proposal that is extremely difficult to implement and will take a long time. And it's to actually reduce the growing cost of disasters.
Okay.
They are wildly out of control. The federal government had been spending roughly $1 billion a week on cleaning up after disasters. Now it's edging up towards $2 billion a week as we have more and more people in hazardous locations, like the faults. And what we're proposing is rewarding good conduct and disrewarding risky conduct. We have a situation where state and local government receive rewards in terms of local tax revenues and do not have a heavy incentive, actually have very little incentive at all to do the right thing. And so what we are proposing is that we, over a long term, reward good conduct at the state and local level, and we do a much better job in terms of the federal agencies doing a better job of conditioning grants and loans and other federal intervention on better quality design, which will gradually reduce our wildly escalating cost of disasters.
So could you give us an example of something where a current practice and how you would change it? What kind of conditioning? For example, I think you talk about tax deductions for property development and standards. So why don't you talk a little bit about examples?
Let me talk about two specific examples. One is tax deduction for property development. The federal government spends an enormous amount of money, and we talk about later in the papers on mortgage interest deduction and other types of deduction, encouraging the development, encouraging home ownership. But to encourage home ownership in risky locations with improperly built and designed buildings and infrastructure is not a very wise choice. And I think we need to look much further than that at how we can reward good conduct. Massachusetts, for example, where I live, we're one of the fourth member of the panel from Massachusetts.
Surrounded here.
Surrounded, absolutely surrounded. Has any number of standards that they have developed over the years to reduce flood losses. Strong building codes. They reduce earthquake losses, as does California. And yet they receive no particular benefit from the federal government for that good conduct. In fact, other states that do not have those standards perhaps receive a benefit by getting very, very generous disaster payments. Another specific example is the design and construction of water and sewage treatment plants under the supervision of the Environmental Protection Agency. If the EPA were to comply with the executive order from President Carter, Executive Order 11988, and design those plants to a 500-year flood level, which would increase their costs by perhaps 1.5% or 2%, we would save a fortune in disaster payments under the Stafford Act. So it's very much along the lines of a stitch in time saving 9, the 9-to-1 payback, perhaps higher, by doing things safely and properly at the beginning rather than cleaning up the mess later.
So a lot of your proposals really assume a pretty high degree of regulatory control. So basically you're regulating. You cannot locate property on this waterfront. You cannot locate property on this fault. You have to build to a certain standard whose standard has to be determined in some kind of regulation in order to get a tax credit. How do you see that? You said it's very long term. Would these regulations come from the state? Would they come from the federal government? Would there be need for another agency to do that? I mean, because there's a lot of regulation here.
First of all, let me say, I'm not saying don't build in certain locations. I'm saying build safely and properly wherever you build. Take into account earthquake, wildfire, flood. Take into account tornado, safe rooms for life safety in all these locations. And I'm not sure that you need another regulatory agency. We've done this. We know how to do this. We don't need pilots on this. We've done this. We had one of the worst records in the entire world of dealing with urban fire in this nation 100 years ago. And over time, through zoning, land use, building codes, we turned from being one of the worst nations to one of the better ones, and we did this by individually rating every community in this nation on their ability to deal with urban fire. So if we were to do this for communities on the basis of them dealing with natural hazards, instead of having this fuss right now that we have where communities have a tendency to try and lower their standards to attract development, we would have communities raising their standards to lower insurance premiums. This is doable. There are suggestions from the American Bar Association about how to do this. There are suggestions from other reputable organizations of trying to involve the insurance industry much more in overall catastrophic casualty losses and rating communities separately so that good conduct is rewarded and bad conduct is certainly not punished, but disrewarded.
Disrewarded, right. All right, fantastic, thank you. I'm going to turn now to our discussant, but before I do, I neglected to say one thing about this panel. I'm sure you've all read everything about the biographies of these individuals, but if not, just be assured that each person speaking here is speaking not just from the point of view of outstanding academic research, but real involvement with public service. In every single one of these cases, people have spent dedicated amounts of time to helping to try to come up with solutions for real problems. I just wanted to say that. So, and that is true of our discussant, Paul Vanderwater, who has been a long time engaged in Washington on issues of health and our general social safety net at the CBO and now at the Center for Budget and Policy Priorities. Paul, do you have some wrap-up observations or questions for our panelists?
Well, just a few comments. As a CBO alumnus, I guess my role, the institutional role, is to play the skunk at the picnic. Bob Reischauer will allow me to share that terminology. So I'd like to raise a few concerns.
Can you be the optimistic skunk, like Alice, an optimistic skunk at the picnic? Go ahead.
I'm the pessimist along with Bob here.
All right.
So have to raise a few political and practical questions about some of these proposals. Now, first of all, on John, actually, I like John's proposal quite a bit, and particularly on the first part of his recommendation, the change in the Medicare cost sharing. I really welcome his attention to low-income protection, that is, having lower catastrophic cap for people with lower incomes, and also, although he didn't mention, as I recall, a lower deductible for low-income people as well. Now, John fully recognizes that when you put these things together, that part of the proposal may actually not save any money. And that's actually a very welcome fact, because we have a lot of proposals floating around Washington now that would change Medicare cost sharing, and whose proponents often argue that they would save money. But I think that if you build in the low-income protections, that's not at all clear. On the surcharge, on the tax on supplemental insurance, again, a welcome idea, but you yourself, Laura, I think raised the key issue about that. It's political feasibility, so I don't need to go any further. On Jeff's suggestion for pilots and demonstrations and disability insurance, I think that idea is extremely welcome, again, particularly in comparison to a lot of ideas that are circulating that would implement changes in the program without knowing what they would do. And indeed, that seems to be the all too typical way of proceeding. The fly in the ointment here is that it's not at all clear, quite frankly, that these ideas that Jeff proposes to test actually would work or would in fact save money. But at least if we test them, we have a chance to find out. Another reservation there too is, I think Jeff and his co-author Jack Smallgan are very well aware. There's also the Social Security Administration, where I've also worked, like other operating government agencies, has, I have to say, a limited ability to conduct demonstrations and experiments, particularly in the context where the agency is under very tight budgetary constraints already. And simply providing additional appropriations and saying, well, that'll be sufficient, doesn't do the trick, because we're talking about, in demonstrations, changing the ways the agency carries out a lot of its day-to-day activities for subsets of its beneficiaries or potential beneficiaries. Now, on Michael's proposal, he actually moves the other way from Jeff. Instead of wanting to test things and see if it works, he's wading into areas where, in fact, we have tests and pilots underway, and he wants to short-circuit some of those and move full speed ahead to implement things like bundled payments, more aggressive accountable care organizations. And there, I think there are some real cautions that are in order. Michael mentioned in passing the major organizational changes that would be required to do that, but I think simply mentioning them hardly does justice to the practical issues that would be involved. Moreover, I think that in talking about moving accountable care organizations to being fully risk-bearing entities, he mentions in passing in his paper the need to perhaps to change the structure of ACOs so beneficiaries would be limited to ACOs. That, in fact, is a big change, because the whole notion of the accountable care organizations is that they're supposed to be something different from the types of managed care we've had in the past. Organizations that would differ in that they would allow beneficiaries to continue to have free choice of healthcare providers. And Michael's approach would seem to backtrack from that. I have some comments about Edward's as well, but we could
Oh,
leave
I
that
think-
for further discussion.
If you, I feel, actually, why don't you make your comments, because we have a little, yeah.
Well, there I think the issues are essentially political, both at the front end and the back end. The basic idea is a very good one: more mitigation of disaster effects in advance, imposing more local responsibility, and then at the end of the day, requiring the federal government to provide less assistance. But the problems are twofold. First of all, will the federal government in fact have to bear a lot of the costs for the disaster mitigation up front? You know, we see the current suggestions the federal government should do that in the case of the New York City area. The federal government has done it in the case of New Orleans and many other cases. But even equally or more problematic is whether or not we can make sure that when the disasters do occur, the federal government actually does hold back and not provide assistance to people who suffer despite the mitigation efforts. That, in fact, is why we've, in part, why we have things like crop insurance and flood insurance with some degree of subsidization. The thought was, when those programs were created, that by encouraging people to buy insurance, albeit with some degree of subsidy, it would reduce the need for subsequent disaster assistance outlays. I don't know if we really know the extent to which that's actually worked, but that was the theory.
So I'd like to give the authors a chance to respond to anything they've heard from Paul. You might want to start, because
Sure, I can start. I think the cost of doing hazard mitigation appropriately belongs with the person that is doing the development, the homeowner, the developer, the builder. The higher standards would not necessarily be imposed. Use the word imposed. I like to say encouraged. If you encourage someone to design and build safely to reduce the risk of urban fire, the community's fire insurance premiums go down. When the community is better prepared, every community in this nation is rated separately by a private market insurance group using a schedule, an insurance schedule, based on their ability to deal with urban fire, including what kind of a building code, what type of zoning in terms of setback they have. And we can do the same thing with respect to other hazards. It's just a matter of doing it.
Why isn't that the case? So why isn't, for example, or maybe it is, in a state like California, is there a private insurance association which determines what safe locations are, what safe building is for?
We don't have that with respect to earthquake.
We don't.
We have it with respect to floods through the community rating system, where a community can lower their insurance premiums by doing the right thing.
Okay.
But that's only for people who buy flood insurance. It's not as universal as what David Conrad and I are suggesting. So I think we said that the federal government had paid billions for mitigation. This is a suggestion by by Mr. Vanderwater, by Paul, and down New Orleans. And I'll have to tell you that the federal government paid a lot of billions. I'm not sure how much of it went to mitigation. There was a lot of gifts.
Gifts, loss recovery.
Just outright gifts given to people. We call them grants, but they're gifts. Let's call them what they really are. With basically no strings attached at all. And folks did what they did with that money. What we're proposing is there would be very stringent requirements on those federal dollars, not so that people didn't rebuild, but they rebuilt safely and properly, and we're strongly encouraged to do that in terms of elevation. And there are wonderful studies by like the Wharton School that talks about the payback to the society when they're building, or in the case of New York and New Orleans, rebuilding a home, when they elevate significantly above the current federal minimum base flood level.
But I was thinking also of the Corps of Engineers activities to rebuild the levees and the other flood protection devices around the city. That was extremely expensive, and is a cost that's been borne by the federal taxpayer, not by the residents of New Orleans.
So the distinction is between physical infrastructure for the nation or for a region, and I think what you're talking about, which is really private property development within that infrastructure.
It is both. The good news about the design, the Nouvelle New Orleans levies, which are actually a system as opposed to the previous set of dirt piles that they had, which is what they were. It was not a system. Is that they are designed to be resilient. They're designed to take a licking and not blow. They're designed that
So there was
when a larger flood than the design flood goes over those levees, as it inevitably will, that the pumps and the levees will not blow, and pumps will keep the water at a modest level. That levee system, the levee system that is known as the Mississippi Rivers and Tributaries, which goes back to the 1920s and 30s, are designed to be resilient. They're about the only levee system I know in the United States that are designed to be resilient. The rest of the levee systems that we have paid for with federal tax dollars are actually designed to blow. They're not deliberately designed to blow, but inevitably when they're overtopped, they do blow, and in turn, they induce more development behind them. So we have these levees that meet really no known standard of engineering excellence. In the civilized world, at least. I mean, by the civilized world, I mean the Netherlands and Germany and Great Britain, and the way we used to do things in this nation. And we're inducing tremendous development behind them that in turn is going to result in further increases in federal expenditures.
So let me turn now to, bring us back now to where, so these are really big long-run savings. We have, in the next 10 years, the need to generate really big 10-year savings, particularly in health. So Michael, Jonathan, how do you respond to some of Paul's pessimism?
Well, so first let me emphasize that what we're facing is choices. So in evaluating whatever you want to evaluate, you have to compare it to the status quo. So I want to take a second and say the status quo fee-for-service system tries to hit budget targets with a series of fee reductions that I'm not sure anyone believes are really sustainable going forward, and does so within a system who has, at best case, no incentive for particular efficiency, and at worst case, stunning incentives for inefficiency. And I will say, apart from that, the amount of time and attention one can spend trying to micromanage the nuance of geographic adjustments or how much you should pay for a level 5 physician visit if it's delivered in this site versus that site, or is stunning. So in that sense, the bar for our proposal is low. Maybe that's the best thing you can say.
Mud piles or the current
the bar
is low.
But no, what I would say is that a lot of the discussions here have to do with the politics and the transitions. And so, as I mentioned, I agree. The organizational changes that are necessary to move to a different system of payments is substantial. And I will say in Massachusetts, since we all seem to be here, the transition has actually been much more successful and phenomenally quicker than I think people would have thought prior. Well, John can say.
Yeah, no, you both can say.
But so I do think there's a lot of opportunity, and I think the experience that CMS has had with organizations applying to become accountable care organizations in various ways has really been quite overwhelming, because I think they realize how bad the alternative is. That said, a lot of our proposal would focus on questions about trying to make the regulations in the different parts of the system that we have sensible and synergistic, which they currently are not for a bunch of reasons. We need very important attention to the quality of care. Obviously, no one has said, although I think it's a reasonable critique, I don't mean to be the other-handed economist, I think it's a reasonable critique that you worry about providers skimping on care when you change their incentives. We need good quality measurement. This issue of benefit design is important, and free choice of provider is important. We didn't mean to imply at all that people wouldn't have a free choice of provider. The question is when and under what terms. And I think there's an important role for CMS in trying to figure out exactly what that means. And more importantly, if the basic contract in Medicare is you can go to any provider no matter how inefficient and no matter what they do, and we will pay in a whole range of ways. Maybe that is the social contract, and I won't argue one way or another, although that is in fact not what we proposed.
That's the current system.
Right, and again, as has been pointed out, The demographics of Medicare are working against you with phenomenal force.
Right.
So even if we were to lower per beneficiary spending to historically unprecedentedly slow rates of growth, the amount of money going into Medicare still goes up. So I was not asked the question about how much money we should tax to funnel into the Medicare system.
No.
We were asked the question about how to come up with a proposal that might be more fiscally sustainable and more importantly would promote efficiency, which is I think we've done. And my personal opinion is that you can't get there in the current basic structure of how the Medicare program relates to the underlying provider system.
Can I ask you, and maybe it'll also segue to Johnson, and maybe a little unfair question. So when I read this first, it's a global cap, you're setting a cap. It's a little bit like saying it's another version, but on the provider side of premium support, on the consumer side. So basically, here's the cap, here's the amount you get, go find your best provider or your best group. How do you compare those two?
So I don't consider this premium support, although you point out there are similarities to it. I think that this is focused on maintaining the connection between Medicare and the provider system and making that provider system more efficient, giving them the incentive so they can become more efficient, as opposed to a system like
premium support, they're supposed to become more efficient by competing.
Right. Absolutely, but the point is they still have to interact with the provider system, facing all the competitive issues you raised in your last question.
Okay.
So we're quite agnostic, actually. I believe that the insurance industry has a lot to offer in terms of innovative ideas for efficiency, and we're quite agnostic about whether or not we should funnel money to a delivery system that has all sorts of issues or to a set of health plans which have their own issues. But we do in the paper argue that we want some sort of synergy or consistency between them. So, for example, in a Medicare Advantage world, we pay organizations based on a county. In an accountable care organization world, we pay based on the people who you've enrolled in the past. And so within a given geography, high-cost places are getting more money than low-cost provider systems. We give the managed care plans a range of tools that they can use in terms of benefit design. They can do much of what Jonathan says, in fact. But outside of that system, we don't give them the same set of levers. I agree in many ways with Paul, which is it would be folly to allow the system to move in a way that had no consumer protections or regulations about where the restrictions are on benefit co-pays or fees if you go outside of the network. So I do think a lot of attention needs to be paid to much more sensible regulation of the system we're moving to, as opposed to how much attention we pay towards trying to make the system we have work better at the margin. And I just think that if we keep tweaking a system that has these fundamental fragmentations and problems, we will be distracted from a system that has incentives for efficiency.
Okay, Jonathan, any responses to Paul? Or anything else
I mean, I think that actually your premium support comment's a good segue, because fundamentally when it comes down to it, one of three parties has to bear the rising costs of Medicare, either the taxpayer, the provider, or the beneficiary. And so far we've been doing it on, well, the taxpayer in the future at least, and the providers, but not the beneficiaries. And then you have on the other extreme a premium support proposal, which would put it all on beneficiaries. So we have to be thinking about a sensible middle ground and a balanced approach. Now, here we have a system which is an outdated, really broken system in terms of the cost sharing people face. What you can do is you can shift costs to individuals and have them bear the costs in a sensible way, which would say, look, we're going to protect you against major risk, but we're not going to let you essentially impose costs on the rest of the system by having insurance that you don't need anymore. And I agree, Paul, it's a heavy lift. And look, the Cadillac tax is a heavy lift, but we did get it. And it's a heavy lift, but I think what we have to recognize is, as Mike said, there's nothing easy on the table. We have to ask ourselves with Medicare, do we want to continue to push and say it all has to happen for providers and the government, and beneficiaries get left out of the equation, which I think is just a recipe for eventually saying, well, okay, fine, let's just move to premium support because that's all we can do on the beneficiary side. I think that there needs to be other good ideas out there on the beneficiary side besides premium support, which bring beneficiary responsibility more into the equation. And I think there's a way to do it, which, and as I said, it's not unique to me. It's an idea that's been floating around. But it's a way to do it which basically rationalizes the way the insurance product works and also gets us out of seniors spending all this money on a product where a third of what they pay goes to advertising and overhead.
So, go ahead.
Well, John, I hope I indicated that I agree with, with the
You're just worried about the politics of the
I'm just
of the
worried
tax.
about the politics, but substantively, I think it makes
No, the politics is,
makes a lot of sense.
that's why you have to pair them.
Yeah.
I mean, you have to pair them. You can't just tax Medigap in today's system.
Right.
You have to pair them. And you have to say that, I think the way one would sell it is to say, look, we have a broken system of protection for our seniors that leaves seniors with enormous bills. And really the way we sold the Part D program, right? If you go back to the debate over Part D, before it passed, it was most seniors had insurance for drug expenditures. In fact, only a small minority of seniors did not. But those seniors that did not were being bankrupted by their drug expenditures, and that's how we sold Part D. We have a similar thing here, which is there are substantial seniors that do not have supplemental coverage who are potentially being bankrupted by their out-of-pocket costs. We need to fix that, but to fix that right costs money. And so we need to pair that with a reform to the rest of the system that makes that money up.
Yeah. Now, Laura, on the other hand, I do have more serious problems with Michael's proposal, and I think that it's easy to characterize or mischaracterize the way Medicare works. But in fact, in many ways, Medicare is one of the better working parts of our healthcare system. The rate of growth of spending in Medicare is less than the rate of growth in the private sector. We are, in fact, as Michael said, looking at very, very low projected rates of growth over the next decade and even beyond compared to historical rates. You look at the new Time magazine article, for any of you who actually waded your way through it, it's, that's one of the conclusions that the author reaches, that Medicare is actually doing very well, particularly in terms of holding down prices vis-a-vis other payers. So I think that I don't accept what seems to be the basic proposition that Medicare is somehow this awful system that needs that's in desperate need of fundamental reform. I think a lot of the changes that are underway, we need to let those progress and see whether the extent to which bundled payments work or how we can make them work, how we can make accountable care organizations work, rather than just to say marching headlong down these roads without further testing.
So let me, I'm running out of time for questions, but I just want to make sure, Jeff, you didn't have any response to Paul, anything you wanted to add?
Well, I think Paul made a very good point, which is that if you look at the history of federal agencies trying to administer demonstration programs, some have worked and some haven't worked very well. Jack and I, when we put together our proposals, were very cognizant of this, and so what we did two things, and there's a longer version than what you have that you can read if you'd like. One thing is the actual delivery of the services that help put people back to work basically isn't done by the government agencies. It's done by either nonprofit providers or employers or private disability insurance companies, and so that reduces the administrative burden on the federal agencies quite a bit. And the other thing we recommended was that the different demonstrations actually be run by different agencies. So HHS would run the state flexibility one, SSA would do the one about people intervening at the time of application, and so that would also minimize the burden on any particular
And you also have the
agency.
possibility of much more state flexibility, so states could do experiments themselves, and then employers. So you actually, I think there are levels of flexibility that are in the system. All right, I think we have time for a couple of questions. So right there, and please make them short, and we'll make the answers short, because we run into lunch one way or the other.
I'm Jeff Burnham at Georgetown. I'd like to ask Jonathan, how much did we sacrifice by not including a public option in the Affordable Care Act? That seemed to me to be an important incentive to make private insurance cheaper by providing an alternative. Could you comment on that?
Well, I mean, that certainly relates to the conversation we're having here. I actually think that it was not as big a deal as made out to be. Here's the example I like to think of. Imagine you're shopping for apples, and there were 3 places to buy apples that were 20 minutes from each other. And the only way to find out what the prices were, you'd have to drive there. And we know in that situation, in fact, my colleague won the Nobel Prize for proving that situation, that each apple seller will set a very high monopoly-like price because of those transaction costs. Now imagine we introduce a 4th Apple provider that's 20 minutes away again called GovApple. Okay? It wouldn't make that big a difference. I mean, if you're near GovApple, you'd benefit. If you weren't, you wouldn't. But instead of that, imagine we introduced an exchange where people could shop on the internet and know exactly what all the prices were at the private Apple providers. I'm enough of an economist to believe that actually that is the bigger difference, and that these exchanges introduced in the ACA are really what's going to matter for introducing competition in insurance markets. And we've actually seen it in Massachusetts. Once we introduced our exchange, we had the first major for-profit entrant into our insurance markets we'd had in decades, and they drove insurance prices down by introducing a new limited network product that was much more efficient. So I think the public option would have been fine. Probably on net it would have been a good thing to have, but it was not nearly as big a deal as it made out to be. The much bigger deal, it's not getting enough credit, is setting up these exchanges which will introduce real competition in insurance markets for non-group insurance for the first time.
That's great. Yes, on the same side, right there. And then one.
Hi, I'm Dr. Caroline Poplin. I'm a primary care physician and attorney. And these days I also work on whistleblower cases for Medicare fraud. With regard, I think you've dismissed prices very quickly. How would this system, or what would be bad about saying we're not going to pay more than $50,000 for a cancer drug unless it increases life by a year, or a proton beam accelerator if it's more than $50,000 a treatment? Because now there's no limit on these things, and prices not only do costs, they send signals into the future, and they tell investors that there's no limit on what we will pay for an expensive treatment, so the treatments just become more and more and more expensive.
So wouldn't the global payment cap for providers stop that?
Well, I think this is a question that's more outside of Medicare, because on the drug side, Medicare has private plans that are competing one way or another.
Right.
And
Right.
within Medicare, we could discuss. I am a big believer in the market. I'm not as optimistic in general as John is about markets in a number of ways, particularly for certain types of products. But I think the main problem in Medicare is not prices for that reason, for the reasons that Paul said. I think there's other problems. Right now, I think the problem in Medicare is whether the prices would end up being too low. And I might add, just to clarify, we didn't propose to get rid of the fee-for-service system. We proposed setting up another system that would operate independent from it. So you'd always have that system under the current law set of prices. But that said, we would have to have a longer discussion about price regulation outside of the Medicare market, which is a broader set of questions, which probably has ramifications that are not as salient for the Medicare program. Now, with the new subsidies and the exchanges and stuff, I do think we have to spend a lot of time and attention thinking about pricing in general in the healthcare sector.
Can I jump in here on this one? I mean, even if in theory someone could make the right benefit cost decisions about which things were worth paying for and which weren't, the idea that the political system in Washington is going to let that work well, I think, has been proven to be false.
Right.
And even if it could do it, it does it too slowly. By the time you do a 3-year study and they pass it and Congress overrules half of it, it's not going to work. The best way to make sure inefficient decisions like that aren't made is actually to do something like a bundled payment or a global payment situation where where those decisions will be made by the local doctors, where they will have a fixed amount of resources for their patients, and they will say, hey, if we're only getting this flat amount for all our patients, we're going to make some tough decisions about what to, but it'll be the medical providers working with their patients to do it. It won't be Washington. I just don't see how we get Washington to do that well.
Right.
Great point.
That's right. Yeah, over here?
Bruce McGlory, formerly Brookings. I think it's for Jonathan. The question of the administrative costs and efficiency of income-related caps on co-payments. Is that, and the same thing is true for premium support. Do we have experiments that show that that's administratively feasible as opposed to absolute payment caps?
Bruce, that's a good question. I mean, we're about to run an enormous experiment in 10 months, 9 months. We're about to, under the ACA, about to run an experiment on a much broader scale of that exact nature. And I think that is an issue. I think that we're quick to run towards mean testing of various ways, and I'm a huge fan in many contexts. But we realize that comes with both potential economic disincentives and with administrative issues, and we have to balance that trade-off against the protection. I think the main thing to recognize is that the benefits of that are so enormous because you don't appreciate, even before I wrote this paper, I didn't appreciate how low the average elder's income is. And you just can't expect the average elderly person to be bearing $5,000 or $6,000 a year in medical costs. It's just not feasible. So I think it may be administratively difficult, but I think we have to do it. And I think we can. I think the way we set it up in the ACA is going to work with some hitches. It's going to be rough in the beginning, but I think once we get these agencies talking to each other, I think it can work.
Any other questions out there? I can't see.
It's like lots of hungry people.
All right. Well, I think I think this is a strong signal of the need for a break for lunch. But let me ask you to join me in thanking a panel for great presentations, great content.